Hi, and welcome to the show. Subscribe at kevinmd.com/podcast. Get CME for this episode by clicking on the CME link in the show notes. Today, we welcome Esther Covington. She's a professional standardized patient. Today's Kevin MD article is titled The Impact of Assumptions on Patient Communication in Medical Training. Esther, welcome to the show.
Thank you very much. Glad to be here.
So we'll talk about your article in a little bit. First off, briefly share your story and journey.
So unlike most of your guests, my background is in the performing arts. And although both of my grandfathers were doctors, my brother's a doctor and my other brother's a nurse practitioner, so medicine certainly runs in the family. And it was my brother, who's a radiologist, who encouraged me to write about my experience as a standardized patient. I started working as a standardized patient 18 years ago. I was actually in a theater company. I ended up falling off the set during a show, and they sent me to the nearest hospital, which happened to be a teaching hospital. And when they asked me how I hurt myself, I said, at work. They said, what do you do? I said, I'm an actor. They said, upstairs. I said, upstairs. And they said, yes, there are actors who they hire to play patients for medical students. So that was in 2005, and that's when I started working as a standardized patient. And since then, I've been working at a number of medical schools in the area in which I live. And when my brother, who's the radiologist, I also enjoy writing as a hobby. And he was the one who encouraged me to write about some of my experiences, because he mentioned that there is a lot written on Kevin MD about the medicine side, but not a lot about the patient side. And so I wanted to sort of add my voice, especially because as you see thousands and thousands of medical students, you start to see some consistent patterns, or you start to realize that there are certainly some consistencies, and I wanted to bring that.
So for those who aren't familiar with how medical education works, take us through a typical day of what you do as a standardized patient.
Fortunately, there is no typical day, but generally, the thing you have to understand as a standardized patient is you're going to see a lot of patients, and it is about consistency. It's making sure that every single student gets the same answers if they ask the same questions, but that each experience will be different because each student brings their own understanding of medicine into it. So it can be a lot of monotony, especially in the cases where you're supposed to be in pain and you're thinking, oh, I have to pretend to have pancreatitis 12 hours today. And that can be very, very draining. The other hard part is that oftentimes you're asked to provide feedback or fill out a checklist as to what they did. And after seeing maybe 12 patients in a day, you forget, oh, wait, did they palpate my abdomen? Did they listen to my heart? And so that's probably the hardest part. The best part, of course, is that you don't have the same day twice, which I like, and that you get to see students over the course of their medical education, from the first day when they come in and they're shaking as they're listening to your heart, to their fourth year where they're confident and they know what they're doing. And it's wonderful to see that growth.
So I've always wondered, how much creative license do you have as a standardized patient? How far off script are you allowed to go?
Not very far at all. And that's part of the reason why they call it standardized, is they want to make sure that you give that same experience to every doctor. However, there is license based on what they ask. If they ask you questions that aren't in the script, you can provide some of your own detail, but you are encouraged to, of course, keep your answer short or things, because you don't want to divert it all. But it's not like in Seinfeld. That's when most people hear, that's what they think is that episode of Seinfeld where he's like, it was a long day. And unfortunately, you don't get to do any of that. But you can sometimes add something lighthearted or add a personal touch to it.
Now, you have a background, obviously, in the performing arts. If someone were to be interested in becoming a professional standardized patient, how does one go about doing that?
If there's a medical school in your area, the best thing to do is to find your education director at the medical school, to contact them and ask about it. Although most of the standardized patients I know have backgrounds in theater or the performing arts, there's a number of people who don't. Especially, it's a fabulous job, especially for retirees. In fact, my father, who's never been an actor, once he retired, started doing standardized patient work at his local school. So the main thing is just you have to have a lot of availability. You have to be willing to take direction well, and you have to memorize, a set amount of information, but it's usually not too hard.
All right, let's talk about your Kevin MD article. You mentioned there are patterns that you've seen after doing thousands and thousands of these. It's titled The Impact of Assumptions on Patient Communication in Medical Training. Now, how did your article come together?
This came because of one particularly heinous encounter with a student who just completely went off the rails, which is very, very unusual. Most students actually, keep within the confines and of their assigned case. But even though this particular student completely went off the rails and told this patient that she was completely nuts and crazy, but the underlying message is one that I've seen a lot, is that so many times with students, and I've seen this with doctors in my own experience. I have a number of health conditions that require I go see a lot of doctors, but there's a lot of people that think that they do know better than the patient, that they have more knowledge about medicine, which they do, but that they're not willing to either listen carefully to what a patient says or trust a patient. And that is consistently where the students and where doctors get into a lot of issues, is by making assumptions based on what they think they know, when in essence, they're not actually listening to what their patient is saying.
So, give us an example. What would be some phrases they would say? What would be a story perhaps you could share that would really illustrate that?
In my own experience, I went in a few years ago because I every time I would get a cold, I would have a cough that would linger for months and months. And so I went in to see a pulmonologist to see if maybe there was something to that. And they ended up doing some breathing tests, and despite the fact that I had told the doctor what my issues were, she apparently had pulled the wrong patient's results off of the printer. And so she came in to tell me sort of the same thing, that there was nothing wrong with me, that it was sort of all in my head, and that maybe the issue was just, was that I don't even remember, but I was trying to tell her, no, this isn't the case and all of this. And it turns out that another doctor actually came in and said, oh, you have the wrong patient's thing, and here's the real results, which turns out I actually had terrible asthma. But because she was unwilling to listen, had she not gotten those results, she would have sent me away and said, no, 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 you're fine. You can breathe. It's all in your head. And so there was sort of this moment of, oh, sorry. But that was also that moment where I said, I'm not ever going to go back to this doctor, because she was not willing to listen when I said, I'm having trouble breathing.
Now, from your role as a professional centerized patient, if you encounter a student who may not be listening as well as they should, what kind of feedback, like how would you give feedback to improve that?
A lot of the time, we don't get to give one-on-one feedback. We have to fill out a checklist. And so that's the sort of thing where I would note to the instructor, and we're always encouraged and to do it in a professional manner. If I am allowed to give one-on-one feedback, it's always in a way of, I'm going to let them know how I feel,
Yeah.
because my experience as a patient may be very, very different. That maybe our personalities were different or whatnot, but I will always let them know that, when you said X, Y, and Z, I felt this way. And I would encourage you next time to perhaps not say this, or next time say something empathetic, or try to give them some sort of useful or corrective feedback if possible.
So you use the word empathetic, and this is a question I often ask. Do you think that empathy can be taught in an educational setting, or do you think it's mostly innate what students bring to the profession?
I think genuine empathy can be taught, but the way that it is often taught is in phrases that sound very hollow.
Hmm.
Somebody who, and this is a very common thing at the medical schools, is, oh, I'm sorry to hear that. Oh, I'm sorry to hear that. And they keep repeating that. You could actually feel sorry to hear, or be sorry. But if I hear that over and over again, it sounds hollow.
Hmm.
But you don't have to say the words, I'm sorry. Sometimes it can just be, that sounds rough. Looks like you're in pain. I'm going to make sure that we take good care of you. There's all sorts of ways to show it. And that I think is innate. It's the way to express that can be taught, and in some ways maybe should be taught differently, because somebody who innately maybe isn't comfortable always saying I'm so sorry, but is comfortable saying, oh, you look like you're in pain, that's empathy. And you just need to go with your instinct more, I think, for a lot of students.
Now, you have, again, like a background in performing arts. Do you think there's any techniques as an actor that physicians or medical students can learn to be better interpersonally in the exam room?
I think one of the reasons why they like actors is because we are able to show pain, perhaps like realistic levels of pain, perhaps better than somebody who isn't. But I think it's especially useful to hire actors when it comes to the cases, the really emotional cases, where you're told that you have cancer or you're told that you just lost your baby or somebody has died, because we are able to bring those real tears and or the real anger when you're talking about the PTSD cases or that sort of thing. And you can see the students really sort of like, yeah. So when the more real your reaction is, the more real the student's reaction is. And that's where it is very valuable to have somebody with a performing arts background over somebody who doesn't.
Now, you mentioned that you've been doing this for many, many years now. Have you seen a trend in terms of the medical students and in the medical education settings that you've seen? Like, has anything changed or evolved over the last few years in terms of the interactions that you have?
Yes, the main thing that I'm encouraged by is I love that a lot of the medical schools are focusing on inclusivity more than they were when I first started. I think that's wonderful, especially since one of the previous articles I'd written about was dealing more with cultural sensitivities and differences. And so I'm really glad to see that being addressed. Unfortunately, the trend I'm seeing is that I feel like a lot of the medical students are being coddled more than before, and that doesn't do anybody any good. To pass a medical student who is not performing well clinically can have dire consequences on the safety and health of patients, and even though they need a safe space to learn, they also need to learn that medicine is a tough profession and people's lives are at stake. And so in some cases, it's like, suck it up, buttercup, you got to deal with this. So that's sort of the downside I've seen.
Now, we have a lot of medical students who listen to this podcast, and for their interactions with standardized patients, do you have any piece of advice that you could share with them? And for that matter, physicians as well, because interacting with standardized patients is really just a reflection of how we interact with real patients as well. So tell us what kind of advice you have to share with us.
Don't go in with any preconceived notions about who this patient is, and listen to what they have to say. That if you are thinking in your mind of the next question you want to ask, you're going to miss what your patient is saying. And whether it's in the doctor's office or whether it's in a clinic, an actual standardized setting, your patients are going to give you hints and clues, especially about hard to talk about subjects or things that they're maybe uncomfortable with. And the more you listen and watch their body language, but just mainly just listen to what they have to say before speaking, and that goes such a long way.
We're talking to Esther Covington. She's a professional standardized patient. Her Kevin MD article is titled The Impact of Assumptions on Patient Communication and Medical Training. Esther, tell us some of your take home messages that you want to leave with the Kevin MD audience.
First of all, thank you all so much for the work you do. Medicine is incredible, and I'm so grateful for wonderful doctors out there. My other message would be to trust your instincts as a person, that everybody has something to add to this. Don't worry about being the best clinician if you know that you are a good listener. If you are a great listener, then maybe share that with your fellow doctors who aren't. But just trust your patients. We're not lying to you. We are there for care. So trust them when they come in with a real issue. And also, and especially for those who work with standardized patients, we're not there to trick you. We want you to succeed. We want you to pass. And so we are on your team, and medicine is a team, and yeah, patients and doctors, and we all want that same outcome.
Esther, thank you so much for sharing your story, time, and insight. Thanks again for coming on the show.
Thanks. It's been a pleasure.